Hello everyone, welcome to HIM 225. This is a continuation of the lecture for Chapter 18 in your textbook, and I'm on page 446, and we're talking about procedures on the stomach. The first one we're going to look at is a Nissen fundoplication. And in the index, if you put in fundoplication, you will see that it takes you to this entry. And this is actually a restriction because basically what you are doing is partially closing off an orifice, which is the esophageal junction when you're performing this procedure. And it sends you to table 0DV4. Once we get to this table, typically the operative note would tell you the approach. Usually it's open. There usually is no device and there's no qualifier. So this is how you would get to the code for this fundoplication. Next, we're going to look at a PEG. Now, a PEG is a percutaneous endoscopic gastrostomy. And when you put PEG in the index, just that easy, bam, the entire code pops up for you. So you can read the description of what that procedure involves and what it is used for in your textbook. Basically, this is a tube that goes through the abdominal wall into the stomach. They use a scope to do it. And typically they put a PEG tube in because they're feeding the patient through this PEG tube. They may actually be being administered medication through this PEG tube. There can be a number of reasons that they put a PEG tube into a patient. Obviously, if they're not eating because they're very debilitated or they have cancer, they may put a PEG tube in that patient. It is definitely a life-sustaining procedure. And many times there are patients that are at end of life, and PEG tubes are put in to maintain them and maintain their nutrition, as opposed to opting for hospice type of care, which would not utilize or have the placement of a PEG tube. If a patient has a PEG already, they can go into hospice, but once they're in hospice, a PEG tube would not be placed. It's typically an outpatient procedure. Sometimes the patients actually will have to come in to have their PEG tube changed. So the next procedure that we're looking at is an EGD. And you literally in the index you can put in EGD and this full code will pop up. Now I want you to notice that the root operation for this is inspection. So if an EGD is done and anything else is done, if they do a biopsy, if they cauterize something, then it is no longer an inspection. And in your textbook on page 447, it tells you that many times additional procedures are performed. They do biopsy, they remove lesions, they do ablations. It might be for hemorrhage control or dilatation. And if any of those procedures are done, then it's no longer an inspection. You're actually going to be coding that particular root operation. I mentioned earlier that patients sometimes came in to have their PEG tubes changed as opposed to replaced. And in the index, if you go to change, and then you come down to intestine upper, you will find this complete code for changing, taking out or off something and putting an identical device in. So this is, if they were coming in to change a PEG tube, this would be the code that we would use. So the next procedure we're going to look at is a colostomy. And in the index, if we put in the term colostomy, we have two options, bypass and drainage. And this colostomy that we are talking about is a bypass. And it's a colostomy that is formed because they have removed colon or they're letting bowel rest for some reason. But we can see that it takes us to table 0D1. and then we need to choose the appropriate body part. Typically, it will be the large intestine. They could tell you that it's the ascending colon, the transverse colon, or the descending colon. I'm just going to pick large intestine. And typically this approach is open. And then there will be, there may be a device that is utilized, and then the qualifier typically for this is cutaneous because it's coming out the skin. And that's what the colostomy that we're looking at in our textbook. It tells us that this colostomy is an artificial opening that serves as a substitute anus through which the intestinal excrete waste until the colon heals or corrective surgery is performed. The location depends on which part of the colon is involved in the surgery. Most of these are temporary. And it tells us that a sigmoid colostomy is the most common procedure before. Your book also talks about the closure, which is called a takedown, so you'll want to read that information as well. On page 448, your textbook is talking about ileostomies and bowel resections. Bowel resections can be a number of different things. You have to carefully read the operative report to code the specific part of the bowel that is resected. And on the top of page 449, we have an example. The patient was admitted to the hospital. They had an open ileocecectomy, and this involves removal of the cecum. So that is a resection. The terminal ileum and the appendix, and this was done for a malignant carcinoid tumor of the cecum. So in this particular example, we only need one code because this procedure code includes the removal of the portion of the ileum and the appendix that are integral to the removal of the entire cecum. So that to me says that you can't take out the cecum unless you are also taking out the terminal ileum and the appendix. So they're integral to the procedure. So in the index, because this is a resection, we put in resection, cecum, and it takes us to the table ODTH. We are choosing the approach. It told us that this was open and there is no device and no qualifier. In the next example, the patient had a malignant neoplasm of the descending colon, and they're admitted for an open left hemicolectomy and then a temporary colostomy of the transverse colon. So we would have the code for the malignant neoplasm. And then this hemicolectomy is a resection. So, but in the index I put in hemicolectomy. So if I go to hemicolectomy, then it sends me to the table 0DT. And I know that this is a left hemicolectomy, large intestine left. And we know that it was an open procedure and there's no device and there's no qualifier. For the colostomy, it was a colostomy of the transverse colon. And in the index we put in colostomy, and this is a bypass, so we're going to choose the table 0D1. We choose our body part, which is the transverse colon. We know that this was an open procedure. There is no device, and this is cutaneous. Our qualifier is cutaneous. These are the options that we have, but this bypass is coming to the skin. So this qualifier is the to part of that. So we choose cutaneous, and that actually is in your PCS coding guidelines with regard to a bypass. Now our next example is for a laparoscopic appendectomy. the patient had acute appendicitis, so we would have our diagnosis code for the acute appendicitis. In the index, if I go to appendectomy, I have two options, excision and resection. Very seldom, they just don't leave any of the appendix in. There may be a time that they leave part of the appendix in. In the past, appendixes have always been removed. They used to be removed prophylactically. A woman would have a hysterectomy and they'd go ahead and take out her appendix. They have found that the appendix does have an important part in the digestive process. And so now sometimes they will only take out a part of the appendix. But if it's acutely inflamed, they're going to take out all of it. They're not going to leave it there. And of course, patients with appendicitis, sometimes they actually treat them with antibiotics and they reverse that process and they don't have to do an appendectomy. But in our case, we're doing a resection. We're taking out this whole appendix. So we're going to table 0DTJ. And what we need to do now is choose our approach. And this approach was endoscopic, so it's percutaneous endoscopic. It wasn't via any kind of natural or artificial opening, and there's no device and no qualifier. So that is how we get to this code. Next, let's look at the bottom of page 449. And this is an example of a cholecystectomy. And in this example, the patient has acute cholecystitis with cholelithiasis. So we will have a combination code for that. Now, this tells us that it was a lap chole, but it was converted to an open procedure. So there is a Z code that we apply when a procedure is converted from laparoscopic to open. We also need to code the open procedure, and the guidelines tell us that if we have a laparoscopic converted to an open, that we also code an inspection. We apply an inspection code. The actual open procedure is sequenced first, and this gallbladder was a resection. It was not an excision. So in the index, if we go to cholecystectomy, we want to choose resection because they're going to remove the entire gallbladder. When we get to this table, all we have to do is choose the approach, which is open, and now we have our code for the open procedure. Next, we're going to look at the inspection. So in the index, I put in inspection and then gallbladder, and that takes us to table 0FJ4. When we get to that table, all we have to do is choose the appropriate root operation. So this was laparoscopic. So it was not opened. It was converted to an open. So percutaneous endoscopic is the approach that we choose here. And so this is our code. So just kind of that quick and easy. In the next example on page 450, this patient had common bile duct stones, and they presented for stone removal by ERCP. So if we just looked at ERCP in the index, we would see that this actually doesn't code to the medical surgical section. It codes to imaging, and this is actually the fluoroscopic procedure. Well, that's not what we did. This ERCP becomes the approach, and the procedure of removing the stones is actually an extirpation. So in the index, we need to go to extirpation. So in the index, I put in exturbation and then duct and common bile, and that sends us to the table 0FC9. Now, this procedure was done via an artificial opening endoscopic. And there's no device and there's no qualifier. So that is how we find this particular code. In the examples on page 451, in the first example, this is a patient who has chronic cholecystitis who was admitted for a laparoscopic cholecystectomy. The surgeon performed manual lysis of adhesions of the gallbladder prior to the cholecystectomy. Now, lysis of adhesions is discussed on page 450. And the lysis of adhesions is not typically coded unless the extent of the lysis is such that it adds more time to the procedure or it's more extensive, that it's not just what is usually found when a surgeon enters an abdomen. So just the fact that the surgeon says, well, I did a lysis of adhesions, it doesn't impact the procedure. Instead, it was more, unless it's more extensive, and it prolonged the procedure, and he had to take time and specifically documents doing that. So you have to be very careful when you're documenting the lysis of adhesions. And in the next example, that was the first example, and we have already coded a laparoscopic cholecystectomy. So in the next example, the patient comes in with abdominal pain. The surgeon performs laparoscopic lysis of adhesions of the peritoneum. In this instance, if you attempt to put in lysis in the index, nothing comes up. So you have to know that when they're doing a lysis of adhesions, the root operation is release. And so we go to release and then peritoneum. And then when we go to that table, let's scroll up a little bit, we choose the approach. And in this instance, we know that this was laparoscopic, so it's percutaneous endoscopic, and there's no device and there's no qualifier. So in our next example on 451, we're looking at the herniorrhaphy. And the herniorrhaphy is a repair of a hernia, and the root operation is repair unless there's some type of synthetic material that helps support that weak abdominal wall. When that happens, the root operation becomes supplement because they're putting in a material. So in this particular example, the patient has bilateral inguinal hernia repair. It's open with a prosthesis. So there is just one code for bilateral inguinal hernias, and then we're going to look up this code. So in the index, I'm going to put in supplement, and then inguinal. It comes up inguinal region, and this was bilateral. So O0YUA. And you'll notice that this goes to anatomic region lower extremity, because where's the dividing line for upper and lower? It's the diaphragm, and the inguinal area is below the diaphragm, and so that's how we get to lower extremities. This was an open procedure, and so we're choosing the approach is open. We did have a synthetic substitute, so we are choosing the appropriate device, and there is no qualifier. And the last procedure that we're going to talk about is on the bottom of page 451, and this is a TIPS procedure, a transjugular intrahepatic portosystemic shunt. This is actually a shunt that connects the portal vein to one of the hepatic veins, and the stent's inserted into a tunnel to keep that track open. Your book tells you that it doesn't improve the functioning of the liver, but it helps to treat some of the complications. In the index, if you put in TIPS, T-I-P-S, nothing comes up. You actually have to know that this is a very specific procedure. People that code this probably code it all the time. You have to know that this is a bypass. And so we go to bypass. And what we are doing is bypassing the portal vein. So we put in bypass, vein, and then portal. And that sends us to table 0618. When we get there, we look at we need to choose our approach. Now, typically this is done by interventional radiologists. So it is a percutaneous procedure. It is not typically, it would not be open. And it's not even endoscopic, it's percutaneous. And they use radiological guidance to help them with this. And then, of course, we are choosing a synthetic substitute. Well, your book doesn't use synthetic substitute. Let me take off percutaneous. This may be a change in PCS that your book hasn't kept up with. Intraluminal device. So we're choosing percutaneous, and even though your textbook has intraluminal device, PCS is telling us that this code is actually J with a synthetic substitute, and then the qualifier is lower vein. Your question for this lecture is exercise 18.7 on page 452, number 1. And this question has two answers, a diagnosis code and a procedure code. You can reference the Coding Clinic 4th quarter of 2013, page 117. So 2 codes, 1 diagnosis code. Patient has dysphagia, and they had a PEG tube inserted. So your procedure code's the dysphagia. Your diagnosis code is dysphagia. Procedure code is the insertion of the PEG tube. Now I'm going to go over the homework assignment. So for the chapter review, you're doing odd 5 through 19. And number 5 has 2 codes. Patient comes into ER with hematoschisia. They're admitted. It's determined that they have acute blood loss anemia caused by diverticulosis. So there are only 2 codes there. Number 7 has 2 codes. And in number 7, we have a patient that comes in with what they think is acute appendicitis, but when they go to OR, they remove the appendix via open approach, and the post-operative diagnosis is ruptured appendix. So this patient has a ruptured appendix, and they had an appendectomy. Number 9 has 2 codes, diagnosis code and a procedure code. The patient came in with an indirect inguinal hernia that's repaired via an open approach with a mesh graft. So you have an inguinal hernia repair. They use a graft. Remember what root operation you have to use for a graft. Number 11 has 2 codes, a diagnosis code and a procedure code. The patient has cholecystitis with cholelithiasis. That's 1 code. They're admitted for surgery. They have a laparoscopic partial cholecystectomy. So partial, make sure that you use the appropriate root operation for a partial cholecystectomy. Let's look at number 13. Number 13 has 2 codes, 1 diagnosis code and 1 procedure code. The patient has cholelithiasis, and they have an ESWL. We didn't go over an ESWL, but that is lithotripsy. The root operation for that is fragmentation. So make sure you code that appropriately. And then number 15 has 3 codes, 2 diagnosis codes and 1 procedure code. In number 15, the patient has ascites due to alcoholic cirrhosis, and they're admitted for a TIPS procedure, and that was done via a laparoscopic approach. Number 17 has 1 diagnosis code and 2 procedure codes. The patient has severe malnutrition, and they're admitted for an endoscopic placement of a gastrostomy tube. This says enteral feedings were done prior to discharge, That code is 3E0G76Z. And then number 19, retained gallstone status post cholecystectomy 1 year ago. Number 19 has two codes. One is a diagnosis code, and the other one is actually a Y code, and I'm going to give you that code. We haven't studied this yet. It's Y83.6. In the workbook for Chapter 18 on page 196, you're answering questions 1, 3, and 5. Let's look at number 1. It's case scenario 1. This is a 63-year-old who has an incarcerated incisional hernia. He has an open repair of that hernia with mesh. So if mesh is used, what root operation do you have to make sure that you use with this? Now, there is that one diagnosis code, that one procedure code, and then there are 3 Z codes. Now, you will sequence the diagnosis code and all 3 of the Z codes before the procedure code. So the Z codes, this patient has a history of prostate cancer. Their prostate was removed in 2002, so they have an absence acquired of their prostate. And he's an ex-smoker. He hasn't smoked for 25 years. So we have a history of tobacco use. Now in number 3, we have a 55-year-old male who comes in with severe abdominal pain, long history of alcohol abuse. The patient is currently drinking a case of beer a day. So they're admitted with acute pancreatitis secondary to alcoholism. They also have COPD and protein calorie malnutrition secondary to alcoholism. For this question, there are 4 codes. So the patient has the acute pancreatitis, they have alcoholism, they have COPD, and they have protein calorie malnutrition. Then we have number 5. Number 5, patient is taken to the hospital by ambulance. They collapsed at home. Arriving in the ER, it's determined that this patient has a history of hypertension and chronic constipation. The patient's admitted for syncope. So after workup, it's determined that the patient collapsed from a volvulus. The patient is taken immediately to the OR for repair, and open reduction of the left descending colon is performed. This, for number 5, we have 4 codes. We have 3 diagnosis codes and 1 procedure code. And remember that our patient has a volvulus, they have hypertension, they have chronic constipation, and they have an open reduction of the left descending colon. For this procedure code in the index, if you put in reduction, you'll see volvulus listed here, and then you can complete that code. That'll conclude this lecture for Chapter 18.